distinguished chairpersons and colleagues. I'm very pleased to be present among you today in the 8th meeting of the Arab Society of Pediatric Clinical Nutrition. أنا بهني دكتورة سناء يوسف على المجهود الكبير اللي هي عملته على مدى السنوات اللي فاتوا، وإن شاء الله مؤتمر ناجح. بهني دكتورة مي نصار، أنا عارفة مجهود كبير عاملينه. وبهني دكتور إيهاب خيري ودكتورة ياسمين جمال، وبتمنى لهم الشفاء العاجل إن شاء الله، يرجعوا لنا بألف سلامة. دكتورة مروة الديب وكل التيم بتاع النيوتريشن، مبروك للمؤتمر بتاعكم. أنا هتكلم I will be speaking now about faltering growth in children in cardiac patients with heart failure. Is it a cause or a result? We all know that signs of faltering growth in patients with cardiac disease include underweight for age, decreased length and height for age, and underweight for height. Which cardiac disease can affect the nutrition and growth? All these heart diseases can affect nutrition and growth: the congenital hearts, the cardiomyopathies, the acquired heart disease, and the cardiac disease secondary to systemic illness. What pathologies cause these heart failure, affect the growth? Mainly it is congestive heart failure, the pulmonary hypertension, and the cyanosis. What are the lesions that present with heart failure? We all know the left to right shunts, congenital heart disease, left to right shunts like the VSDs, which is the most common congenital heart. They are the ones that usually present with heart failure. Everybody thinks that maybe cyanotic heart disease do not present with heart failure, but actually they do. Most of the complex congenital cyanotic heart disease have heart failure, like the transposition of the great arteries or a single ventricle, and they are both cyanosed and with heart failure. The obstructive heart lesions, they present with obstruction, like aortic stenosis and coarctation. They end up with heart failure. It's a late presentation, not like those. It's an early presentation. Cardiomyopathies might present early with heart failure, especially the dilated. The acquired multivalvular heart disease presents late with heart failure, and we are not seeing in the first years of life, and thus it doesn't really cause this falter growth in early infancy and the first few years of life. Pulmonary hypertension arrhythmias may also present with heart failure. Our difficult combination is the presence of cyanosis and hypoxia, heart failure, and pulmonary hypertension together with one another, because management of these patients is difficult. The presence of heart failure necessitates the use of diuretics, and these diuretics may predispose the cyanosed baby to thrombosis, particularly if there is anemia. So that's a really quite difficult combination to manage. It was found out that 29% of the cardiovascular diseases have underlying malnourished, they are or undernourished. 27% of them are below the 3rd centile for both weight and height. In the Children's Hospital Ain Shams University, 53% of the patients of the cyanotic heart disease patients were below weight for age. So what's the epidemiology of faltering growth due to congenital heart disease and heart failure? And I'm repeating again, heart failure is the main pathology in this age that leads to faltering growth. It is highest between birth and 3 years, mainly in the first year. It is very difficult in the first year when the baby is growing and is supposed to be increasing in weight rapidly. This is the time that he's mostly affected. Some says it is more common in boys, but we know that different cardiac diseases have different patterns of growth. This chart shows the different nutritional risk factors that affect growth, put by Marino et al. He divided the cardiac conditions into low risk nutrition risk, medium nutrition risk, and high nutrition risk. And if you see in this table, the PDE is present in the new low nutrition risk if it's a small one. and it is present in the high nutrition risk if it is a big PDE. So the size of the lesion or the extent of the lesion affects the general condition. Now, if we look closely, we find that some of the lesions like coarctation of the aorta, total anomalous primary venous drainage are put in the low risk here. But not in all areas, not in all countries, it is a low nutrition risk lesion. No, sometimes it is a high nutrition risk lesion. So what are the causes of variability? Why the nutrition risk varies in different parts of the countries or different areas. The medical services are different in different countries, and even the medical services in the cardiac centers are not the same. You have to have a cardiac center that is fully equipped. They have the pediatrician who detects early. They have the nutritionist and the dietitian. They have the echocardiographer. They have the interventionist, and they have the cardiac surgeon. This is a complete treatment for the patient. But in many countries, there are rare centers like this. And this delays the time of detection of the lesion. Not in every place it is detected early. Literacy of the mother has got a great impact. The financial status of the family, as we're going to say later, and the patient additional disease. So the nutritional risk actually varies from one place to another. So the degree of nutritional risk of the cardiac defect varies from one place to another. A low risk cardiac lesion in one locality might be a high risk cardiac lesion in another locality. So we have to study in all circumstances together if we want to assess the patient. And we have to understand that the low socioeconomic standards really have got an impact on the faltering growth in congenital heart disease patients. With delayed time of detection, they present quite late because the mother usually is not aware of the seriousness of the condition, and it is a financial handicap. The mother is not aware of the seriousness of the condition, or she's not aware of the condition itself. Sometimes the mother says هو لونه كده من ساعة ما اتولد، هو لونه طب مش واخد بالك انه ازرق؟ لا ده هو كده، هو شكله كده. بينهج؟ لا هو نفسه كده، يعني هو مش نفسه سريع شويه، هو طبيعته كده، هو من ساعه ما اتولد كده، هو ما فيهوش حاجه، هو كويس قوي. طيب عنده ثقب في القلب، معلش جيراننا الثقب بتاعهم قفل، هو كمان هيقفل. يبقى الجار مثلا عنده small VSD and this is a more severe VSD or a complex heart, but they are lacking of the awareness of the seriousness of the condition. The financial handicap, although many times the doctor's visit might be free in areas, but they have to pay also for the transportation, which is not easy for some of the patients. They have to get some supplements and treatments, and moreover the surgery. So what are the causes of faltering growth in patients with heart failure? An inadequate intake, an inadequate uptake, increased requirements that are needed, caloric requirements, other congenital anomalies, syndromes, or inborn errors of metabolism, for instance, a cleft palate present with a cardiac abnormality or a renal problem. This will compound the problem for the patient, and prenatal factors. If you look at the baby who is having heart failure and is suckling, he's poorly suckling and swallowing. So he has got a rapidly breathing, and he's trying to suckle amid his rapid breathing. There is definitely lack of coordination between both, and the baby will aspire. Many times they have developed aspiration. This leads to infection, chest infection. And this aspiration makes the baby, and this abnormal in coordination, they fatigue easily. They have early satiety or simply tired. With oral aversion, all these lead to feeding difficulties with the mother, and the mother, especially if that's her first child, this is a very big problem for her. She's not able to feed her child. Now again, we are also restricting the fluids in those babies. So there is fluid restriction leading to inadequate intake of enough nutrients for this heart failure patient. Now, sometimes the patient is taking enough intake, but there is inadequate uptake. He's not using what is being taken due to hypoxia and poor absorption in the gut. due to edema of the gut or hypoxia due to cyanosis, and the presence of gastroesophageal reflux with aspiration and vomiting. It is very important to know that vomiting is one of the signs of heart failure. It is an early sign of heart failure. Some babies present simply with vomiting, and do not consider it as a GIT problem. It is treatment, its management is treatment or more control of the heart failure. Diarrhea can also lead to inadequate uptake due to decreased immunity and repeated infections in patients with faltering growth. These babies have increased requirements, increased basal metabolic rate. They need more to the muscles, increased energy spent on difficult breathing, the respiratory muscles, and the accessory respiratory muscles. They have an extra work and they're working excessively, and thus they need more energy together with the heart. Instead of working, saying 110 or 120 beats per minute, it's working at 150 beats per minute. This is an extra work, an extra amount of energy that is needed all time, every minute of the day. Prenatal factors, it is seen in some patients in which we find a small defect, small VSD, with no hemodynamic significance whatsoever. But when you look at the growth potential of this baby, it's not good. He's underweight and underbid. These are prenatal growth potentials that are affected. And the mother always is insisting that it is due to the defect, the congenital heart disease. I think both are due to prenatal factors. Why is undernutrition serious? Why are afraid of the heart failure and the undernutrition in these patients? Because it affects the cognitive and neurological functions of the child. This leads to repeated infections with further deterioration of the general condition and more faltering growth. It also, very importantly, leads to delayed surgical intervention. There are certain congenital heart disease in certain areas the doctors don't want to operate except on a certain weight, and the baby is not reaching it. And it definitely affects the surgical outcome. Baby with affected nutrition and poor growth have bad surgical outcome with increased morbidity and mortality. So now we agree that heart failure will lead to faulty nutrition and faltering growth. So does it always go in this direction that cardiac disease with heart failure leads to undernutrition and faltering growth? Or can it be that undernutrition and faltering growth can also lead to cardiac disease with heart failure? So we need to answer this question. So how can the undernutrition or malnutrition affects the heart failure? The undernutrition is associated usually with repeated infections. If you watch a child with a heart failure, with a defect shunt with heart failure, he's taking his medication, هو متلصم يا دوبك with a balance كده هوت. Once the infection occurs, the baby enters into heart failure because he is on a very fine balance. This infection deteriorates the general condition and increases the heart failure. With the presence of fever, with the presence of lung pathology, and so on. This is a whole lecture by itself. When we have intractable heart failure, we tell, we ask, please exclude anemia, electrolyte imbalance, and hypoalbuminemia. These three, when present in undernutrition, they increase the heart failure and they precipitate heart failure. Vitamin D is very important. We have found it to be very defective and affecting the myocardial functions in patients of cardiomyopathy, and we have published this in literature. Thiamine deficiencies, the zinc, the selenium, and the magnesium are very important for cardiac function, so is carnitine. And moreover, lack of energy due to undernutrition will affect the amount of energy taken by the increased demands, which leads to an unable for the muscles to be working properly with increase in the heart failure. So how we assess growth? We know all these, the routine in investigations with weight, height, and weight for height, and the non-routine. And the baby, the infant has to be put on a chart, a growth chart, in every visit. This is a routine for every newborn and every infant. because you detect early the faltering growth on this curve. Here it started to fall. Already he's at the bottom of the curve and he's faltered. It started faltering right away. Okay, and we can see how much it is decreasing, and the weight is also decreasing before the height is affected. We have to take the dietetic history with recalls and estimate the calories, watch the behavior of the feeding and feeding interactions, psychological and socioeconomic factors. But in order to manage cases, we have to understand that we have to control the cardiac conditions. So to treat faltering growth, we have to manage to treat the heart failure in patients, control the heart failure with anti-failure measures, give nutritional supplementations according to the nutritional plan that we're going to talk about, and exclude other system involvement because there might be an additional factor that we are overseeing. This is a nutritional plan in which we classify the congenital heart disease risk that we mentioned before, and then again, we're going to tailor it for each patient. We know what is the risk in each particular patient, and assess and classify the infant's growth. Where is he standing as regards his growth? How does he eat and drink? And what does he eat and drink? And then you choose a nutritional plan, plan A, plan B, or plan C. In plan A, the baby is okay. He's in his normal centile. So we're going to feed him as he's being fed as a regular baby, and you're going to follow him up regularly. But in plan B, the infant is not growing well, and he's growing between 1 to 2 centile below the birth centile. Then he's having one of the lesions with a little bit higher risk, and he finishes only part of his feed, 75% of his feed. He's taking around 120 millis per kilogram per day, so I have to give these feeds in a concentrated form. So in this baby, I have to see him every week, check his weight and see what he's eating and how he is eating to increase his weight. In plan C, the baby is really affected with more than 2 centiles below the growth curves, more than 2 centiles below it. He has got a high risk lesion, and he's might require nasogastric tube. In these babies, we have tried to interfere without nasogastric tube, and we had actually good results. The fluid intake is less than 100 millis per kilogram per day, but these babies should be seen on narrow basis, closed basis, seen every day, every week, because in order to monitor their growth and interfere when appropriate. Now, what type of milk we're going to give? We're going to give the breast milk. It is best. We use it because of its nutritional and immunological good effects. We know that sometimes maybe it has got some inadequate caloric and protein content for increased metabolic needs, and the baby is unable to suckle. And I have heard some people saying that suckling, breastfeeding is not tiresome for congenital heart disease babies. No, with heart failure, it is. Because for years I've been watching these babies, and definitely a bottle is easier for them. But again, breast milk is to be tried also. In this case, we have a high caloric density formula and can be used as a complementary feed or alternating with breastfeeding. A formula, if we're going to use a formula, it has to be high protein and calories with restricted fluid intake and low sodium. The standard formula has got a 0.67 kilocalories per millis, but we prefer for cardiac patients to give more calories if we're going to use an external formula if the patient is in need of it. Because sometimes the babies in severe congenital heart disease, they might require up to 120 to 160 kilocalories per kilogram per day. Before, we used to supplement to make a heavy meal. We used to put supplements or increase concentrations, and this is the formula we used to use. It was not everybody knew how to do it, and it used to take a lot of time for us to do this concentrated formula using the standard formula in making it a more concentrated formula. But nowadays, we have a high energy infant formula with high density formula with 1 kilocalories per milli. And we have been studying this. We've done a work on the nutritional support using this high energy infant formula in pediatric congenital heart disease patients with faltering growth and with good results actually, but we're going to show it later. So if you're feeding the cardiac patient properly and yet the baby is still having faltering growth, why is that so? Maybe you have an incorrect diagnosis. You are missing something. You are missing an arrhythmia or an addition congenital heart disease, or maybe endocrinal or a renal problem, or a genetic problem, inborn error, whatever. You are controlling heart failure. You are not controlling heart failure, and you are not aware why. Probably there is inappropriate medical cardiac treatment. What are the clues that there is inappropriate control of heart failure? Number one, look at the liver. It's very important. Hepatomegaly, the liver, if it starts to enlarge. And very important, our topic, the faltering growth. When the baby starts to having faltering growth, you should know you are missing something. He is not well controlled, his heart failure. Look at the type of drugs used, because the combinations are important, the doses and how you're going to administer and when in relation to one another because of drug interactions. Specific nutrient deficiencies, like for instance selenium in patients with Kishan syndrome, they have cardiomyopathy because of selenium deficiency, so you can supplement and the patients before the patients develop the defect. We have to understand that sometimes there are congenital cardiac defects in which no medical treatment is effective. You have to do surgical interventional procedure to improve your patient. So my take-home message, the answer is heart failure precipitating undernutrition and faltering growth, but also undernutrition and faltering growth can precipitate heart failure. And thank you.